Now, the Magitiximab also was approved. So in America, there are 8 drugs, 8 targeted agents for the treatment of HER2-positive breast cancer. But in China, we only have Trastuzumab, Pertuzumab, and TDM1, and Lapatinib, and Pyrotinib. So it's different. We don't have the TDS 8201. We don't have the Tucatinib. So that I think it's the drug difference. Yeah, I think the sequence we in China we also the Trastuzumab, Pertuzumab, the taxane the first line. This is standard. For the second line we use the capecitabine plus the pyrotinib. The third line more we don't know with the good drug approved in China. So we suggest the patients that go to the clinical trial. And with the approval, Chinese doctors now we have 2 options. One is TDM1, the other is pyrotinib, which one is more standard. Maybe we pushed our Chinese pharmaceuticals to conduct some trials compared head-to-head, compare the TDM1 with the pyrotinib in the second line setting. And also we want to design the clinical trial, TDM1 plus with or without pyrotinib.
In the US, the treatment recommendations based on guidelines are to treat with Trastuzumab and Pertuzumab for node-positive breast cancer combined with chemotherapy. For patients who have node-negative disease, the recommendation is to use Trastuzumab alone with chemotherapy. In patients who receive neoadjuvant therapy who don't have a pathologic complete response, the recommendation is to receive TDM1 for 1 year, 14 doses after surgery. In the metastatic setting, we are generally in the first line setting using the Cleopatra-like regimen with Trastuzumab, Pertuzumab, and a taxane, then TDM1. Then you could use either the HER2 Climb regimen or you could use the Trastuzumab deruxtecan. And now following that, we have a choice of using Margetuximab or also Neratinib. Tendency to use HER2 Climb for patients with brain mets, and then Trastuzumab deruxtecan for patients who don't have progressive brain metastases. There's been a lot of interest if a patient has brain metastases to use Tucatinib in the HER2 Climb regimen earlier, not waiting till the 3rd line. And Trastuzumab deruxtecan, because it works very well, there's a lot of interest in trying to move that earlier as well and into the post-neoadjuvant setting also. But currently, this is the general recommendation that these new agents fit into 3rd line or greater in the metastatic setting.
We have the TDM1, but it only approved for the neoadjuvant non-PCR patients. So it's the adjuvant setting.
Oh, interesting. Not metastatic.
But not metastatic. So that in China now, our standard treatment first, second line is capecitabine plus pyrotinib.
Mm-hmm. It's a very active combination, pyrotinib, although it does cause some diarrhea. When you give pyrotinib, do you use a dose escalation like was used with Neratinib?
No, we use the maximum tolerated dose, 400 milligram per day. Then we use some drugs, anti-diarrhea, the drugs. I think that most patients can be handled, managed very well. So in my clinical practice, no patients discontinue this drug because of that.
Oh, interesting.
Yeah. It can be handled.
Even capecitabine, because we have some patients who tolerate capecitabine very poorly, but you don't have so much.
Yeah, I think it seems Asian patients tolerate the capecitabine, tolerate the 5-FU drugs much better.
Yes. Yeah, different metabolism. But what do you do in China now after the second line treatment?
Mostly it suggests the patients to enter the clinical trial.
I see.
Yeah, a clinical trial. Also, some patients can get the TDM1 from outside China. They get it.
That's very good to have that option. And what is the trial for Trastuzumab deruxtecan?
We entered the breast 02, Destiny breast 02, breast 04, and low HER2 low breast cancer, the breast 06. I think that we have the 4 clinical trials, deruxtecan trials ongoing, recruiting patients in China now.
How in China is it common to use neoadjuvant chemotherapy with trastuzumab and pertuzumab?
Well, we have some neoadjuvant study, especially in our center. We have a high volume hospital, so the more neoadjuvant studies in our center.
Yeah, we do a lot of neoadjuvant therapy. Now there is a lot of interest in giving just either docetaxel or paclitaxel with trastuzumab, pertuzumab, then going to surgery because you can do the TDM1 after surgery. So a lot more people are getting neoadjuvant therapy.
It's great. We also push the more patients in the neoadjuvant study. Because for these patients, if not get non-PCR patients, they still have other drug available.
Yes.
In the adjuvant setting. So for these patients, can get the more chance to get cured of their disease.
And what's your standard chemotherapy for early stage disease?
For neoadjuvant, for the HER2 positive disease, we also mostly use the regimen is the taxane plus carboplatin plus trastuzumab, pertuzumab. So it's the TCHP regimen.
Right. Same adjuvant, yeah. Same treatment adjuvant. Yeah. We also are using that more because I think the recent data suggested from TRAIN 2 that you don't need to give anthracyclines anymore.